2017. Let's take a brief moment to review a few items. At this point, all of our lines are muted for the webinar. For you to enter questions that you may have for today for our presenter, LeRoy Jones, please enter those into the chat area as shown here on the diagram. Questions will be addressed based on time remaining. Questions not responded to, please request a follow-up or contact GSI Health directly. All attendees will receive a link to the webinar recording by September 23rd, 2016. I'd like to take a moment to introduce you to our speaker today, again, LeRoy Jones, who is the founder, president, and CEO of GSI Health. LeRoy Jones founded GSI Health to help solve a problem: uniformed, uncoordinated care being practiced in today's healthcare system. He strives to drive innovation in healthcare IT industry to create a world in which data-driven technology optimizes care delivery and ultimately results in healthier patients and populations. Lee has helped several states develop architectures and operational models for healthcare information exchange and has contributed to a number of federal programs and industry initiatives that establish standards and shape the future of healthcare IT. He has served as a senior advisor to the President, appointed National Coordinator for Health Information Technology, responsible for managing the strategic technical directions for the national healthcare agenda. Under his leadership, GSI Health has pioneered working models for effective collaboration and community-based care delivery and become an industry leader in population health solutions. Lee holds an MS in Engineering and the Management of Technology, jointly from the Wharton School and School of Engineering and Applied Science at the University of Pennsylvania, and a BS in Computer Science with Carnegie Mellon University. It is our pleasure to have Lee share his information today, and we hope that this allows you to have a vision and look into what is ahead for each of us as we look at care management versus analytics, where to begin value-based programs like DSRIP. Again, thank you for joining us today and look forward for your attendance and questions in our future webinar series. Lee, I'll turn this over to you. And again, thank you to everyone.
Thanks so much, Melanie. I appreciate the introduction, and I certainly appreciate everyone who's joined us today. We will go through the material that you see listed here in our overview, and the broad topic is ostensibly talking about DSRIP, and we can in our question and answer and in some of my comments address particular DSRIP-oriented questions. But I think that the principles that we'll be discussing will be applicable beyond just DSRIP and in value-based programs in general. And so I look forward to any detailed questions that you might have, and please follow the instructions that were given about how to place those. I wanted to begin by just giving you some context about GSI Health so you understand what shapes our perspective. We are a population health management solution provider. In particular, we provide a platform that enables coalitions of providers of various types, whether they're medical or social or behavioral or home or other, to collaborate in the management of their common patients and bring them to an appropriate level of health while at the same time managing an entire population. We do that through the facilitation of care coordination and collaboration activities, as well as analytics to understand how those activities are going so that you can have continual improvement. And so what I'll be talking about today is based on several different things. One is the experience that we've seen in our client base, and as they've stood up various programs, DSRIP and Medicaid Health Homes and other programs that are akin to that, as well as research that is from the broader industry perspective, and I think resonates with some of the topics that we're going to talk about. So I want to begin by just talking about this era that we're in of value-based care and the promise of riches that that's there. So everyone knows, and I'm sure this crowd in particular is familiar, that value-based programs are now proliferating far and wide. It started with some big pushes from the public payer communities, and now we understand that all of the private payers are following suit, and there's a number of different kinds of programs that all are getting at this same general idea, which is in order to provide adequate care, we have to address the patient's entire set of needs, and that the determination of the efficacy of that care is based upon the value that accrues to the patient as well as the providers and payers. And so this is the premise that has spawned this whole resurgence in what we now call population health management and collaborative care underneath that. And from what we understand, all of the growth projections, all of the convergence of these different kinds of programs, the additional populations that will be managed under this kind of scheme just grows the pot bigger. And most larger or sophisticated organizations are going to have multiple kinds of value-based programs, whether they are DSRIP or health homes or ACOs. Patient-centered medical home has obviously had a long tenure now, and there's a lot of literature about the successes and challenges there. But the movement toward collaborative care and addressing the entire patient's needs and managing an entire population is here to stay and growing stronger. And so what the hope is, obviously, is that this will pay off, and pay off to a number of different constituents. First, we want to make sure that all populations gain a wealth of health. Everyone should receive better care. They should have care that's more efficient and effective and timely, and that is sort of the payoff that we would expect for members, patients, and populations in aggregate. But there should also be a payoff for providers of all stripes. They should get a wealth of incentives and savings and a chance to have gain share opportunities so that they can continue to practice profitably, and they are more in control of the revenue that they're able to get for applying their trade, and at the same time meet those value measurements for their patient populations. And then ultimately, if we can bend the cost curve, then the insurers and ultimately you and I who pay for health insurance will also gain, because there'll be cheaper health care and there'll be savings to be had for all. So this sounds great. Everyone is winning, win, 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 and if only we knew how to get there. How is it that we achieve these value-based care programs, do them effectively? There have been a number of mixed results in the marketplace. ACOs of the earlier models have started to report results. There's mixed reviews about how effective they are. There are different kinds of factors that people are reporting in terms of their success in analogous programs, whether it's patient-centered medical home or private ACOs, et cetera. And so I think, though, that we've gone far enough that there are some lessons that can be learned and some patterns that can be exploited. And so when we're starting into a new program, whether you're in DSRIP in a new state that's just signed their Medicaid waiver, or you're continuing on in a program and you're either a late entrant or have been participating but not at the caliber that you expect to, this idea of reformation of the system is at the core, and I think that the industry can teach us some things. So Captain Reformation here, who's been observing what's going on in the industry, can offer up some guidance for us today. And we know that there are a number of models around the country that have been publishing and presenting at various conferences about ways to turn their efforts into good health outcomes that we all recognize. And there are a number of different tactics that are starting to coalesce and take form that are at the beginning of being repeatable. And so best practices are starting to proliferate. But this is still early in the game. And so Captain Reformation can't speak entirely authoritatively to say that in every instance the things that we'll talk about today will work perfectly. However, I think that the collective wisdom and the viewpoints that can be gleaned from what's been discussed so far in the industry will certainly apply broadly. So, given those caveats and that explanation of the captain's viewpoint, he has a map for us to offer so that we can find our way to that value-based treasure. And so when we think about trying to get to that promised treasure, we are here in the kingdom of population health management. Population health management has started to be inextricably linked with the concept of value-based care. And we're starting in this world of population health management from our delivery system as it exists today, whether we've been a long time in these collaborative models or just starting out wherever we are, we have to move in the same direction. So the challenge here is, how is it that we move across the kingdom of population health management? We go through the sea of trial and error. Maybe we make a stop at the Isle of Improvement, but ultimately try to make our way to the land of value-based outcomes. And these value-based outcomes often are the measure of these programs on how well they're doing. It could be a whole battery of outcomes or one macro outcome, such as reducing readmissions by 25%, or it could be associated with particular disease characteristics, et cetera. I think that there's a whole gamut of approaches that we see as these programs roll out across the country. But making our way across the kingdom of population health management, there are different things on the landscape that we notice. There's coalition castle. There has to be a point in time where the network that is going to form to treat the population coalesces and makes their set of agreements so that they understand their respective roles and how they're going to share in the gains and how they're going to share in the treatment of patients. There's the technology volcano, a very explosive topic because there's inevitably the use of technology is required to do the kind of work that's envisioned in most of these value-based programs, and everyone has something. There are incumbent systems, there are public utility kinds of systems like HIEs, there are a number of different vendors who offer different slices of functionality. And so this is a volatile topic in a number of communities as they start. There are the workflow warriors. When we talk about doing something new, it often means that people have to do something new. And doing something new comes at a cost. An opportunity cost, maybe an out-of-pocket cost, but the decisions on how a group of entities who may not be used to working together actually start working together and changing their workflow can be a challenge. And so you have to fight those battles through those workflow warriors to arrive at the collaborative model of care that's going to work. The population tar pits. Many programs get bogged down trying to define and understand the population that they're serving. Most understand it and may even be able to enumerate who and describe who that population is. However, when it comes to actually executing upon that population, to gather the information that's required together to start to approach the population in a concerted way, there are often a number of issues that arise that are barriers, and people can get stuck as they try to understand how to move forward. There are mountains and mountains and mountains of data. There's data in electronic health records, data in HIEs, data in internal admin system, data from payers. You name it, there are silos of data that everyone seems very interested in pulling together in order to do the good work. There's the black forest of analytics and reporting, all kinds of measures and counting and calculations, things that are retrospective, things that are prospective, a whole bevy of options on how it is that you actually can measure and do more advanced kinds of analyses on not just the data, but the population and the people who are delivering care. And often it's like going through a forest and trying to understand exactly what you need from it and how you can get out of it. And if you make it through the sea of trial and error, you often find out that you didn't do it right the first time. And so there has to be a way for you to facilitate change. And the merchant of change here is the facilitator who helps you to find your way toward the land of value-based outcomes in an effective way based on the infrastructure that you put in place. And so when we look through the landscape that we have to traverse, there are obviously many different directions that one can go. And so there are choices that are facing you and choices that I'm sure will be familiar as we go along. So I want to start with a cautionary tale, but before I do that, I do have one poll that I would like to administer to the audience, just so I can understand the perspectives that we have here. And so I'm going to launch a poll now and would ask that you would respond to it. And I'm asking a question: which factor has been the greatest challenge for your DSRIP or other value-based program? And there are 5 choices: partnerships or network building, technology, data or analytics, workflow or operations, population determination, or other. And so I'm going to launch this now. You should be able to see the poll, and I'd ask that you would respond, and I will close the poll out after we've gotten some responses in. So I'll pause here while people are responding. All right, I'll close the poll in about another 10 seconds. Great, thank you. And so I can share the results of the poll. As you should be able to, as you are able to see, a number of you have said technology, data, and analytics have been the greatest challenge. And then closely behind that, partnerships and network building. I'm going to presume that's related to, but not exactly the same as the 21% who said workflow and operations. And so thank you very much. Now you and I both know the makeup of the audience that we're talking to. And so there are a number of different choices that you are that avail themselves to you when you start to go down this road. And for some of you who are veterans now, you may look at this road to DSRIP or other value-based programs and conjure up thoughts of Dante's Inferno. Abandon all hope, ye who enter here. Sometimes it seems very daunting to do things in a restricted time frame that you haven't been able to do for the entirety of the organization's existence. Meeting lots of measures, getting lots of partnerships, collaborating with people that you're competitive with, et cetera. And not unexpectedly, there are a number of paths that, in our experience and some of the research, have not been the most productive paths for people. And so as we think about that, there are some words of caution that Captain is offering. You set out to grasp gold in your hand, eager and earnest with vision so grand. But for this to come true, some things just won't do to reach the value-based outcome land. The key words here is some things just won't do. And I'm going to start by just talking quickly about some of the paths that seem to be less productive for programs as they move down these territory. And so the first that I'm going to discuss is the path that leads into the winds of programmatic change. So we observe that sometimes programs will sign up, they'll get their partners, but they will spend time trying to understand the exact dimensions and requirements of the program. They spend lots of time in meetings trying to get clarification, discussing things with officials, bringing them back, having boards and committees go through them, and there's a lot of analysis and a lot of discussion, and as soon as they think that they might have a way forward, there's some change that happens. And that has led to a lot of programs sort of getting stuck and failing to launch because they're just following and moving into the teeth of the program and being dependent upon how the program moves. And so to get beyond that, or to avoid that, you have to accept that the program guidance, whether it's from the state or some other official organization, is never going to be perfect, and it's going to change. If you accept that perspective, then you won't be fearful of moving forward, because you'll expect that whatever it is that you're doing, there's going to be a change coming. And if we do things that are good for us as an organization, as a coalition, those things may actually turn out to be trendsetters, and they can influence the way that the winds blow instead of being blown about by them. A lot of programs that start with this wait-and-see attitude often find themselves behind the 8 ball with short durations to accomplish big things. And so our encouragement here is it's better to be on the forefront and make it your own. Be an influencer. Be one who goes out and establishes what things are good, because it's very likely that things that will be good for you will be good for the program and be good for others as well. The second path that I want to talk about is hearkening to the siren call of analytic value. And so many programs or many organizations, when they come and they start a program like DSRIP, there'll be an immediate examination of all of the different analytics and measurements and other things of that and reporting that's required. And people will sort of start into, okay, our task is really to do these measurements. And if we do these measurements, then we will be on our way to the land of value-based outcomes. The measurements themselves becomes sort of the target as opposed to the purpose of the program. And that is a siren call, and you can get dashed on the rocks. The outcome measures that are often put forward by these programs are not likely to be adequate for you to measure how well you're doing in terms of the activities that you put in place. It's one thing to look and say my readmissions have gone up or down or compared to what I've expected them to be, but you have to understand why they did. What was it that you did specifically? Furthermore, a lot of the data that answers some of those kinds of questions has erratic availability. So you may be based on claims data where there are adjudicated claims that have multiple month duration. You may not be able to find out your answers until you can do a retrospective analysis far away from the time that you've actually performed the services. And so the outcome measures that you have may not be your best measures for your program, and they also may just be a grab bag of things that have good value, but were ultimately not designed specifically for value-based programs. They are useful and they are helpful in understanding the way that things should operate, but they were taken out of context from other kinds of programs. So HEDIS measures or JCO measures or other things that may be used. And at the end of the day, those outcomes are really only proxies for activities. So if you know a particular outcome was or wasn't achieved, the question is, did I do something that purposefully achieved it, whether I thought that I did or didn't? And if so, how can I improve, and what specifically do I need to do differently? And so the captain recommends that you analyze what you do and not just the result of what you do. The next path I want to look at is sort of on the opposite end of the spectrum, where people will start a program and really feel that, hey, we're doing okay. We're a top-notch organization. We have good practices, and so we don't really need to consider something different. We just need to keep going how we are, and we don't need to worry so much about evaluation because we understand how well we work. And that may be fine if you have a very self-contained organization and you're just essentially applying your own best practices to this model. But if you're in a collaborative scenario where there are other entities involved and other best practices to contend with, even if you're a lead organization, that siren call can dash you on the rocks. Sometimes, partners can bring things to the table that conflict with your best practices, but can ultimately make the collective better. And so if you aren't able to measure how well you're doing as a group, then it's virtually impossible for you to understand what it is that's going to move you forward or what has happened in your environment that has moved you backward. And so sustainability of your program gets jeopardized when those things are the case. And so measurement is very important, and you can improve what you don't measure is the advice that the captain gives. The next path that I want to talk about is this idea of I'll start out and I understand that there are particular analytics that are required and there are certain data that I need to calculate that analytics or to fulfill my reporting. So I'll take a little trek through the mountains of data and I'll gather some things together and I'll take a trek through the black forest of analytics and reporting and try to marry these things up. And when we do that, sometimes that pushes your population health management program into the realm of information technology. And you can be pulled down to a watery grave by the information technology sea monster. And so when a population health management program that is concerned with building care teams and coordinated care plans and managing populations to a specific set of outcomes that filter down into specific activities of care for patients, those things are not IT. IT is an integral part, it's foundational and supportive, but a number of times when you start to bring the question of data and analytics that are being accomplished through certain tools and IT infrastructure, then the entire project becomes an IT project. And IT projects often are governed according to different sets of principles than the operational organizations may be governed, and there could be a slowdown, there could be miscommunications about priorities, there could be misunderstandings about the real objectives. And so management and operations must be the overseer of your analytics and your information in order to serve the program goals. Population health management does not equal IT, and you don't want to fall into the clutches of that kind of monster. The next path is similar in that you go through the mountains of data and pull things out, but because you know that there's not a burden on you to do calculations, it's going to be centrally calculated, then your task sort of boils down to just providing data to a data consumer who will give me a report card of some sort at certain intervals. I call that passive measurement, and that is also a sea monster. And it's a sea monster because when the measurements are centrally calculated, you have an over-reliance on how you believe that you're doing. You have the greatest perspective on what your program really is, and therefore you're in the best position to do the measurements. And if you outsource that because of the existence of a centralized calculating function, then you lose your ability to change, to affect change, and to improve upon your program. And often the insights that you will actually get back from that centralized function won't be tremendously helpful in your advancing your cause. So you're the best measurer because you see all the dimensions of what is going on. And so I wanted to just point out some of these paths that we've seen and we've read about that have sort of befuddled programs and gotten them off to a weaker start than they wanted to. So before we talk about how to go to the riches, we wanted to talk about how not to go, or at least give you the benefit of paths that others have chosen and why they may not have been as successful as they anticipated. But now it's time to go on to a heroic campaign. And the captain certainly has words of wisdom for you here as well. Charge to the healthcare hero. There be a great value-based treasure to be had if you meet every measure. But to all those who dare, using too little care, you'll scarcely enjoy this rich pleasure. And the key phrase to listen to in the captain's words here is this idea of too little care. We do not want this idea of calculating measures and being responsive in reporting and starting to analyze data and organize data to crowd out what the real activity is, and that is the treatment of patients, the treatment and management of populations, the bringing about of wellness so that the population can accrue those benefits as well. And so there's a paradigm that has been really codified in the definition of population health management. So Chilmark Research makes a statement here saying that population health management is the business of care. And the 3 points that they point out here, passive to proactive, defined, financially linked network, and collaboration with the community network, all speak toward a different proactive stance toward this, toward the delivery of care. No longer is it waiting for care to come to you or care needs to come to you, but it's really approaching and reaching out into the market to discover what the care needs are that you can do something about, and then taking those steps. And that whole mindset is one of moving forward and being proactive. And so the rule number 1 for heroes is get started. There's always going to be time to do analysis and course correction, but you need to get started and get moving. The question that was posed in our title is, which comes first, analytics or care management? And I think that the answer is both. You cannot go forward and measure something that you're not, you haven't architected to do the job, and you cannot go forward and do a job and not have any idea of what you're doing. So they really are closely coupled and tightly interwound. However, it's clear that when you're talking about actually achieving the outcomes that are put forward in DSRIP and other programs, that is a function of coordination and care management. In other words, doing analysis gives you some insights, but doing the care management activity gives you the results. And so if you're going to err on, are we going to be more quantitative or are we going to be more operational, I think that erring on the side of being operational, learning lessons, generating data, understanding the true nature of the problem is something that will pay dividends. And in fact, if you read most of the publishing, where there's much more around patient-centered medical home, which is obviously different than DSRIP, but the concepts of care coordination have shown that there are lots of benefits and real tangible results that can be had when we step up our care management and care coordination game. And it has the benefit further is you don't have to wait until the end, until you get to this land of value-based outcomes to gain value. You and all the stakeholders that we talked about before will gain value along the way as you increase your transparency with your network, sharing data, understanding what other people are doing in the care of your common patients, you being transparent, being able to control a process, understanding there's a defined workflow that people are going to adhere to, and you can expect certain things at a different level of confidence than you have in the past. Knowing that there's a measurement and a way to assess how well you're doing at any given time. Being able to look forward prospectively and do analysis and predict and understand solutions and paths that are going to be effective before you reach those critical situations. and then having the power to change the course that you're on in order to take advantage of all the lessons that you've learned. This idea of gathering these jewels will be done as you traverse through this kingdom of population health management. And so the riches are not at the end of the journey, but they're actually scattered along the way. And so if we return to our map, we look at a path that we can go through in order to get to this land of value-based outcomes. And so we again start at today's delivery system, and we move immediately to Coalition Castle, where we can assemble our group of partners. We are able to determine what kind of providers of various kinds, again, whether they're medical or social or behavioral or home or others, are going to be a part of our care delivery model. And it's more than just having people agree to participate and sign your application, but rather starting to build the beginnings of a team among all of the partners. And so those kinds of activities will give you transparency and control that you will get along the way, and you don't have to wait for the treasure at the end. You'll get the benefits of that in your care delivery today. So the conventional wisdom says that you should have the broadest coalition possible, but having a coalition that is so broad that it has no real boundary and it's not able to be controlled is counterproductive. And so you have to always have an eye toward, we need to be able to implement change and get better. And if my network is so vast or so nebulous in the way it's constructed that I cannot govern it, then you're likely going to be frustrated as you go down the path and you discover there are changes that need to be made, and it's very hard and unwieldy to make those changes. Coalition members should agree to work with you as partners, not as someone who's signing up for a program, but you both have to put your hands to the plow and do real work. And so the network of partners that you choose have to be more than just your Rolodex entries. They actually have to be someone that's on your side and on your team. And figuring out that partnership model certainly is not the most straightforward thing, as evidenced by our poll. Sometimes if you're a convening organization, you may control a lot of the partners. And so the same parent organization obviously has degrees of freedom to implement change and do things that unaffiliated organizations don't. You may have unaffiliated organizations that have a direct financial relationship, and so there is some lever, or there may be a lever that is more relational. So you have referral relationships that are not going to be that could be jeopardized if the partners are not doing what's required. Or there are people in the network who provide services who aren't affiliated with you in any way. And there has been a lot of talk lately about ACOs because people say there is no network. The patients are free to go where they want to go, and so how is it that we sort of contain and meet measures? I think what we've seen is that there's sort of a blended approach, but when you're trying to craft your governance, you want to design your measurement and design your targets for measurement around the parts of the network that you can more closely control and count upon. So even if you have others that are a part of the network, you want to make sure that the ones that you actually are counting on are ones that are close and who've agreed to do what you're doing. The next leg of our journey is moving from this coalition castle into the technology volcano. So it's always volatile, but if you can choose the right technology early on, it can help you with every dimension of your efforts for population health management. Obviously, population health management is an activity unto itself. It's not the same as the treatment of an individual patient. It's not charting. It's not the free flow of information. It's something that incorporates and co-ops those things, but doesn't supplant them or replace them, and also is not substituted by them. And so having a solution that helps you specifically with population health management seems, in our experience and reading, seems to make more sense than trying to stretch pre-existing solutions beyond what they were originally intended to. And I understand that there are a number of vendors who have incumbent solutions where they've been able to augment their offerings with population health management, additional offerings, and that may work great and fine. But I think that lots of the conversations that are had when you're considering how to manage population health in terms of technology often center around, well, we have a system that I spend more time in, even if that time is doing something that's not population health management per se. It may be in treatment, but I spend so much time in that system that considering something else for population health management is not on the table because it changes my workflow too much. I think that has been an Achilles heel, this idea of I don't want to have multiple systems, I don't want to do double entry, I don't want to entertain that there could be systems working together. Those kinds of rationales have slowed down a number of programs because ultimately they find out that there is something else that's needed, and they often have to go through those steps, but now it's later and they've fallen behind. Electronic health records and health information exchanges were put into place for their purposes, and they serve them well. And they should be a part of your population health network, but you should not try to take them just because they exist. You should make your requirements for what you need in population health, and then if they fit that, fantastic. If they don't, then you know that the evaluation calls for something else. Also, allowing all of the partners to just bring their own technology and having 1,000 flowers blooming in the network that's supposed to collaborate together has not seemed to work especially well in a number of cases. There's, inevitably translation losses and other things that will retard your progress. And so making sure that there is some commonality for people who are supposed to be on the same team, like they're wearing the same uniform or using the same field, is there. And it's not just an attempt to allow everyone to stay in their comfort zone to the detriment of your larger collective goal. And then lastly, as I mentioned earlier, we don't want to tilt too far to the analytics side and neglect the care delivery and care management and care coordination. And so an analytics package alone as your population health management strategy, again, we're seeing is not always sufficient and has delayed people in moving forward with their program because their insights don't have a place to land in a coordinated way that they can impact their programs the way that they want. So an EHR is not an HIE, and neither is a population health management platform. And so just being very clear about what your program needs actually are in this technology volcano will help you. And there's always going to be a bigger macrocosm that you're a part of. And so it's not to say that anything you do should not play well with others, but it's important to understand your boundaries because, again, the idea is being able to change as required. And so you can have defined boundaries for your affiliation in your network and still exchange information with other networks so that you have the benefit of control and also of transparency that goes beyond your immediate partners. The next leg of our journey takes us into the workflow warriors. This is an area where people have to actually change behavior and do things in a way that may be either inconvenient or at the very least new, and therefore it requires some getting used to, some training, and some time to get acclimated. And so there is the ability to gain some control if you do this well and you take on these conversations early on, so that when you need to really move on a dime with your process, there's already been an understanding that the workflow has been massaged and tailored for all of us to work together. Population health management is about integrating people, not integrating technology. And so it's not, can we have some interoperability that allows my workflow to stand independent and I can throw something over the transom. It's about how those two users of various systems are now on the same team and what do they need to have in common in order to do a good job. Co-opt as many things as partners bring forward that are practical, but at the same time insist upon some commonality that makes the team. And I always think in those terms as opposed to just having partners or subcontractors or other kinds of relationships that are less team-like. Fight those battles early and get people working together, and it will pay off for you as you go forward. One thing that population health management has really brought to the fore is this idea of a coordinated care plan as the place to codify a lot of those rules and those heuristics that the team needs in order to work together. They can be made up of various protocols, whether they come from the evidence or best practices that are local, or even organic entries because there are new players who are around the care planning table. And the coordinated care plan at least has brought transparency, which I think is the first step toward having a more collaborative tool. And there are different models that people have taken. One is to say that the coordinated care plan is shared by all and everyone collaboratively contributes and has access to and therefore can work together with one another in that fashion. The other has been more of a command and control where a care manager or care navigator is a broker for the broader network and keeps sort of the master goal copy or standard of a coordinated care plan. Obviously, there can be different flavors of this. There can be blended approaches, but having that idea of coordinated care plans for the care as a centralized tool for a care team is something that will help you in these workflow wars as you go forward. The next leg of our journey moves us into the population tar pits, where sometimes there are extenuating circumstances that make this process more difficult than one may have anticipated. So, for example, in the New York DSRIP case, there was an attribution that was given to all of the different organizations, PPS as they're called in New York, and that was a list of, or rather a collection of patients and a number that the PPSs were responsible for. But there was lots of confusion in the beginning about whether they were named patients or whether it was just a number, and what happens to patients who cross over, and will I actually get information about these patients? Are the claims going to come to us, or do we have to just mine them out of our own systems? Then there were security requirements about accessing data, and long story short, there was a lot of angst around who is the population that I'm actually responsible for. If you can get to the point where you know and understand who the people are, even if it has to be a smaller chunk than you originally anticipated, defining the boundaries of your population pays off for you and allows you to have a stronger program going forward. There seems to be three basic approaches to defining that population. One is sort of not defining it, just taking criteria and saying, I'm going to deal with asthma patients or whatever it is, and as they come across the threshold, then I will put them into these programs and manage them appropriately. Another is I'm going to look at all the information that I have about all the patients that I think meet these criteria and create my master cohorts, and then use that as my target population, and then I can do some analysis on them to see if there are proactive steps that I have to do before they come across the threshold in order to engage them or do other things. And then a third approach is someone is giving me the list of patients. Either they've predetermined who it is, or it's an attribution with characteristics, and it's a bigger swath than I may have seen in my own jurisdiction, but I might be getting some data about them, and therefore I can start to treat them as a whole population. I think that no matter which strategy you choose, trying to commit to managing the largest population that you can aggregate together will help you, because the whole idea about population health management is that there's a population, and having a group of patients that is too small for you to do meaningful population measures and statistics on so that it can guide what you ought to do will not move the program forward in the way that you may want. And so there is a difference between a population and a bunch of patients. And so you want to try to be thoughtful about who is in the population and how you actually engage them and work on them. And that sort of brings this idea of stratification of a population. Where is it that we want to spend our time? And this particular subtopic often is made large when people are trying to embark upon programs, but often not really implemented when it comes down to execution. And so I want to just make sure that we're all thinking about stratification, which is sort of the breaking up of a population into different categories, in the same way. First, there are what I'll call risk factors, which have to do with the present state of a patient or the history of a patient and something that I can say about them. What was their historical length of stay? Do they have an acuity upon admission? Do they have any comorbidities? What is their pattern of ED visits? Are they compliant? Do they have certain social determinants? Do they fall into measures that I might have, like core HbA1c control, A1C control? Whatever it is that I know or have known over time are risk factors. They've already happened, and they may make, in my view, a patient more or less risky for certain outcomes that I'm trying to avoid or manage. There's a second category, which is predicting the risk or the likelihood that something will happen given a number of those risk factors. And so there are different models. LACE is a predictor model. Homer, there are many commercial risk models that vendors will bring to the table to help you predict readmissions, 6 months, 12 months, et cetera. There are others that you can get in various domains. But these are really trying to not just assess the current state of a patient, but say something prospectively about what will happen to a patient. And so when you're talking about building cohorts so you know where to spend your time and what patients are worth your while, they can really be drawn by risk factors or predictions or a mix of both. The risk factors themselves can contribute to different predictions, which can be part of your cohorts. Similarly, you can just take certain risk factors that you think are particularly telling, like certain HEDIS measures or acuity scores that you may have, diagnostic groups that you want to just care about, and you can mix and match them into composites or take them individually. So slicing and dicing and being able to work with your patient population beyond just assigning some sort of score to them is an important thing, and it'll help you to direct your time and effort. So if you were just taking risks, you may have a whole panel of risks predictors that you pay attention to, and you will have your own internal weighting as to which one you think holds more water. Similarly, you could just take a number of risk factors. What's the PAN score? What's the acuity score? What are they on our HEDIS score for HbA1c? Or you could look at those things together and say, I'm going to have a weighting factor and create a composite risk that takes all these things according to how important I think they are, and I'm going to use that one measure. Whatever it is that you do, the message here is you don't have to have something super fancy in order to create the cohorts that you need in order to do your job and do your work. And so while risk stratification sometimes takes on this really big title and people have to demonstrate really fancy things, you really have been doing risk stratification your entire career as you've decided, and prioritized among different patient populations that you work with. And in fact, Chilmark has borne that out and says that many people now are defining their own proprietary risk groups, which have subgroups that they have determined according to what seems important to them in their own personal history. And so you are on safe ground, at least in the emerging patterns that we see in the industry if you take a less aggressive stance toward what risk stratification means and really just focus on stratifying in ways that you understand and will serve your purposes. So in the next leg of our journey, we start to climb through these mountains of data. And data has lots of inherent challenges that we could spend all day talking about. But I think that if you're able to have a reasonable governance structure around the data that you need for your program and take the addition of that data in chunks so that you can incrementally build upon it, then you'll be able to gain value along the way rather than having a large data exercise that could slow things down in an operational sense. Your data that you are using for your measurement and analytics should be a byproduct of the workflow that you set up. Because if it isn't a byproduct of that, then it may not be close enough to your activities to actually give you a good indication of how well you're doing. And so when you're designing your workflow, understanding the data that will be thrown off by those activities and where it's thrown off to and how you can get to it is a key activity. This whole category of data that I'm calling coordination data is something that has come to the fore as care plans and interventions and goals and issues have really become more prominent, as opposed to just relying upon data that you find in EHRs or that you find in the claim around procedures and diagnoses and drugs and that sort of thing. And so that's an important development because those activities that are part of population health management that are outside of the direct treatment but are part of the management of care are ones that you're going to have the most control over changing to try to facilitate better outcomes. And so that is an important consideration when you're talking about looking at data and what data do we actually need. And obviously, as the care teams grow to include providers that are not medical providers, then the accommodation of different kinds of data and different data elements and factors has to be taken into account. So be vigilant about data governance without being preoccupied with it. Don't let it stop you from treating patients and starting to get your arms around those populations and doing things with them, because you'll learn lessons even if you don't have all of your data questions under control. And in fact, people can get so into the data question, going through the quality of it, trying to validate it, trying to normalize it, understanding the source of truth, figuring out where things are sparse and where they're not. How does this impact and skew models? That it can be distracting from trying to do what is, at the end of the day, job number one, and that is the management and care of the population. The next leg of our journey, if we go through those mountains of data, is to venture into this black forest of analytics and reporting. And if you go in there and you're able to choose wisely among the various options that you have for reporting and analytics, and wisely meaning things that you can actually accomplish and things that are actually going to give you information and help you improve, then there's a lot of reward that comes out of that. Every dimension of population health management can be impacted by the wise choice of your analytics and how those things link into your care delivery model. And so you collect lots of jewels in that forest if you are wise about how you go through it. And so analytics should be integral to the management activity. They shouldn't be just a backroom activity where people who have PhDs in statistics and such things are crunching data and they come out with charts and graphs that can't be easily interpreted and translated into activities and actions that people have to do to alter care. But rather, the management activity that is closer to the delivery of care should also be able to avail themselves of certain kinds of analytics that allows them to analyze their jobs and the jobs of the people who work for them and the jobs of their teammates or their team they're on. You should prioritize analytics that help you get better and help you get better in a timely way. So having to wait a long time before you have any feedback about how you're doing, especially with a lot of the research showing that the patients are very transient as they move up and down these different stratification tiers, and so you only have a limited amount of time to impact them. You don't want to have to wait a long time to understand what you're doing. So pick things that you can actually monitor actively and very frequently, and that will help you improve. And if you improve, then ultimately these other analytics that you've put on the side, I'm sure will improve by extension. And you don't need to do every kind of analytic on day one. You can choose those that help you to get started and continually add on. The good thing is, if you're having data that is naturally thrown off by your process, then you can use that as your litmus test for things that are appropriate for you to measure and to analyze. And when it starts to stray beyond that, you have to ask yourself if the requirements of the program are actually good for my local care delivery models that I'm trying to establish in my community, in my organization. So population health management analytics is a form of care in and of itself. And if you do it wrong, then you can be a source of harm because you're not doing the due diligence in order to understand the appropriate needs of the population and therefore doing the best job that you can to help them. And so this idea of limiting measurement to program outcome measures, because they are the program outcome measures that are required for reimbursement or payment or whatever it may be, incentives, is a little short-sighted, and you likely will not be able to scale just based on those, but you really have to do an assessment for yourself of your care delivery model and how it is that you're going to leverage the information to get better. Chillmark has sort of borne that out and has shown that people are starting to move more and more toward the assessment of their activities, their process-based measures, to assess their effectiveness and not just outcome measures. So if we make our way through the Black Forest and collect all of those jewels, it's time that we now have wandered all the way through the kingdom of population health management and can venture out into the sea of trial and error. And as you try things and you have successes and you have some failures, it's important that you're able to change what you're doing so that you can actually get better over time. And so the Isle of Improvement is the home of the Merchant of Change. But it's interesting because the Merchant of Change can sell you things that will help you to have a better and safer journey to the land of value-based outcomes. But if you don't have any currency to pay that Merchant of Change because you haven't collected any jewels along the way and tried to go through some of those earlier paths, then you might find yourself not having the benefits that you expect out of your program. And so getting that jewel of the change management is a precious one indeed and will pay for you in the end. Those foundations of care delivery being established and the management of the infrastructure that supports care delivery is going to allow you to be more nimble and to be able to meet the changing requirements of the program and to be able to understand if any requirement change or change of environment is actually good for you. And so to be that flexible and that able to facilitate change in your care delivery, it costs something. It costs you some groundwork up front. It means that you have to spend more time thinking about how we all work together than how are we going to do reporting. It means you have to spend more time training people on doing things the right way as opposed to just training people on what they need to submit as evidence of certain activities, et cetera. This improvement that we've been talking about throughout this talk is a key factor in any value-based program because we all will want to continually improve, and the share that you gain from those improvements benefits not only you but the entire ecosystem, as we talked about in the beginning. And so upfront effort pays dividends in the end. And if you look at anybody's virtuous circle, I'll just use this one from Chilmark again, there's always a step of refining and changing and doing things that make you better. This is always a part of the emerging definition that's now getting more and more solid about what population health management means. And if that is the case, then investing in a program that you know you'll be able to implement this refinement is a key to your success as well. Indeed, if we look at our map, if you are willing to invest those early days and go through the wandering and sometimes seemingly circuitous route through the kingdom of population health management, you'll discover when you get to this aisle of improvement that there'll be a current that carries you more quickly to the land of value-based outcomes, the current of strong foundations, the thing that allows you to be able to move and change and do what's required in order to achieve things. And you can get to those value-based outcomes faster because the current of your foundation has actually helped you move along. And similarly, this merchant of change can help you really hone in specifically on the target. Where is that treasure going to be found in this land of value-based outcomes? Am I really trying to achieve the goals that are set there, laid out? Is there a different set or combination of goals I can achieve to maximize my value? This is a large landscape for value-based outcomes, and I want to know precisely where I'm going to go to get the optimal return. And so if you're able to put in the work and build those foundations, you'll find your treasure at the end of your journey, and you'll get there in a stronger position than if you try to take some of the less successful routes that have been discussed in the earlier part of the discussion. So with that, I'm going to just summarize what we've heard from Captain Reformation and his observations from the industry and from experience, and then we'll be able to see if there are questions that have arisen. Once again, I encourage you, if you have questions, to type them in, and we'll be coming to them shortly. And so the takeaways that the captain has shared with us: it's better to be on the forefront and make it your own. Don't be paralyzed and stand back in the face of these new value-based programs like DSRIP. Be on the forefront of actually making changes, and you'll be an influencer. You'll be able to bend things in your direction rather than be blown about as other people do that bending. Analyze what you do and not just the result of what you do. Process versus outcomes. It's not one versus the other, it's both. Cannot forget to analyze the process that you're going through, because that's where you're going to find your biggest gains and improvement. You can't improve what you don't measure. It's very important that you have a particular philosophy and point of view about what you're measuring and why, and how that's going to advance the cause, as opposed to just generally throwing around lots of calculations and reports which don't amount to the changes that you want. Population health management does not equal IT. It's not an IT project. It's supported, and IT is integral and necessary for you to do it well. However, the project of integrating people together and organizations together to take care of patients cannot be just relegated into the IT realm. You are the best measurer of your own program because you see all the dimensions. You're the one who has the best perspective, and so even if there are others who are going to, in a centralized fashion, measure what you do, it behooves you to have your own measurement program so that you can validate what those external measures may do, but also so that you can continually improve and take into account measures that are beneficial to you, not just ones that are generically published for a program. The partners that you have, they have to be more than Rolodex entries. They have to be real partners who roll up their sleeves and they help you define what the work is so that you can do it as a team. And don't mistake the different incumbent systems that you may have as by default being the solution that you will use for population health management. They may very well be, because different vendors have different capabilities. So I'm not trying to say that there's no case where a particular electronic health record or HIE offering could not get you where you need to go, but I am saying that you should think about what your population health needs are from the perspective of that program and set of programs, and not from the position of, this is what I already have, how can I make it work? Fight the battles to get people working together, because, again, this is about people being on a team and figuring out a workflow that's going to work across sites of care, and involves significant transitions of care, and that requires, good working relationship. There's a difference between a population and a bunch of patients. Defining your population in a specific way that enables you to take hold of that population and analyze it in a way so you can do the optimal job and vector your resources and time effectively is going to be efficacious for you. Be very vigilant about data, but don't get preoccupied with it. If you have to err on the side of doing versus analyzing or collecting or trying to cleanse and report, then err on the side of doing, because doing will beget data and you will continually be massaging data to make it better. It's an unending job. Population health management analytics is a form of care. You should think about it as integral to the care delivery model, because it should inform people on how to do their job better and do it in a rapid way, so that you don't have to do wholesale big bang changes after you learn things and experiment over big periods, but you can do small incremental changes all the time and have continual improvement. And finally, upfront effort pays dividends in the end. It may seem like a route, there may be faster ways to try to make it across that sea of trial and error, but it's fraught with peril, and it behooves you to think about how you can do things in a way that's going to be sustainable and going to enable you to improve over time. So with that, I want to thank you for your time and attention, and that's the conclusion of the presentation that I wanted to give. And so now we'll go and check to see what questions may have come in. So I'll take a moment to do that, and Melanie, if there's anything you need to announce, certainly you can come in at this time.
Wonderful. Thank you so much, Lee, for sharing with us today. I hope that this provided everyone items to consider and to think of. Please reach out to GSI Health if there's any additional questions that you may have beyond today. There have been questions coming in. If the presentation will be available, it will be placed on the GSI Health website as of September the 23rd, and we will be sending out a link to that to everyone that attended the webinar today.
And so, Melanie, I don't know if if you see the questions. The display I have doesn't have them in there, so I'm not sure if
we do have a few. Yes, we do have a few questions, and those were initially about the access to the webinar, and then also there's a question requesting, can access and the barriers to access be considered another risk factor?
Access and barriers to access, I'm presuming that means access to care, so that, for example, there are certain populations that may have barriers that prevent them from having primary care physicians. They may use EDs as a form of primary care, or may not have access to best care, et cetera. Presuming that that's what you mean. Yes, I think that certainly that access to care for any number of reasons sort of falls into this whole idea of social determinants and the environmental effect that it's had on your ultimate care efficacy. And so certainly I think that can be a risk factor, and it is that as opposed to a risk score, if you will, because it's talking about your current state or your history.
And we have an additional question that's asking regarding timelines from beginning to decision of how to move forward. Is there a recommendation that you have regarding being able to put things into a timeline perspective?
Sure. So I can speak to, I guess, our experience with our customers. Typically, what we've seen is many customers, when they come and they're starting a program like DSRIP, for example, they are marching to an external clock, and so there's often some driver that they feel some urgency about. And if I had to characterize what that period of time typically is, I'd say most people come and start to get really serious about wanting to get their program up and launched, people trained, technology chosen, workflows worked out, the collaboration and who are the partners, all done within sort of a 90-day period. Lately, we've been seeing even shorter periods of urgency that people have, I think, because they may have gone through a round and realized that they had to make some of those changes, and the changes weren't because they hadn't done some of those other things earlier. The changes were harder or produce a different level of urgency. But I would say that, again, we don't try to boil the ocean, but you can do certain things in a staged fashion, and you can frankly design your programs accordingly. So in our poll, a number of people said that analytics and data and technology were a significant factor that was retarding progress. Well, if you're going to roll out a system that enables you to do coordinated care plans, you may not have to have every data feed and every data interface up and going before you can start to record data through the care planning process, which then becomes yet another data feed. And then those things can be reconciled together later on as you have a greater luxury. But I think that generally speaking, people usually have a 60 to 90 day urgency to try to do a lot of those things that I called the kingdom of population health management to get started.
Thank you, Lee. We have an individual requesting GSI Health experience with DSRIP programs.
Yeah, so GSI Health has been active across the country in a number of these value-based programs, and specifically with DSRIP, we have experience in New York State, and so we have the largest attributed PPSs in the state as customers, and we've been able to bring a number of those programs live. The DSRIP in New York is broken into a number of different sub-programs, if you will. And so we've been able to do a number of them and bring them live over the last half of a year, and then are slated to bring another bevy, another half dozen or so live in the next 30 to 60 days. And so in addition to that, we have customers who are not the conveners for DSRIP, but participate in other DSRIP programs that someone else convenes. And so in that way, we have a number of different, a dozen or so different Medicaid health home partners who actually are participating in various DSRIP programs across New York State. And so we have pretty good experience, all of that caveated by the fact that everyone has only had so much history with DSRIP, but I think comparatively speaking, we're very experienced.
And then it looks to be our final question. When looking at value-based programs, what other programs do you foresee moving forward or next direction with DSRIP or after DSRIP?
I think that a lot of these programs are starting to converge. I think the fact that the idea of population health management is sort of central to most of the value-based programs, whether they are Medicare or Medicaid, or they're ACOs or health homes or programs like DSRIP. I think that all of the tenets are starting to converge. So I think what you're likely to see, and we're actually seeing this in our client base, is you have some organizations who can win a DSRIP, which probably speaks a little bit to their level of sophistication. And they will have multiple programs that they are managing, DSRIP alongside of a Medicaid health home, alongside of an ACO, et cetera. And those populations will overlap. And so what we've seen is that they will borrow the care management infrastructure, for example, of a Medicaid health home, and use it to support the ACO that they have. And so this sort of commingling of the infrastructure, because they've taken the time to build the infrastructure in a scalable and transferable way, allows the kind of incentive program that they're actually servicing to be less significant. So I anticipate bundle payments being integrated heavily into ACOs and other kinds of programs. I think that anything, if you look at health homes and DSRIP both serving the Medicaid population, there are natural mergers and synergies there, and also Medicaid ACOs that are sort of starting their lifespan. So I think that the short answer or summary is all of these things sort of come back to the same set of problems of collaborative care and analysis, and how you can organize teams that may be unaffiliated to work together as if they were. And for that, I think all the experimentation with Medicare is doing with MACRA and MIPS and those sort of things are just confirming that we've hit upon the way to do it. We just have different ways to incentivize it.
Lee, I believe at this moment that is our last question of the day. I would like to thank you and everyone else for attending and looking out for our next series on October the 19th, Creating a Community-Based Network. And Lee, I'll turn this back over to you for final comments.
Well, thank you very much. I appreciate everyone who was able to join us today and to stay on for almost 90 minutes. We certainly have a belief here at GSI Health that if we can move the industry forward in our small corner, then it's good for everyone. And so we try very hard to be informative. I certainly would appreciate any feedback that anyone has about the material that was presented here today, good or bad, because we want to make sure that we bring things to you that are useful and helpful. And so thanks again, and look forward to seeing you on future webinars that we offer.